because most of us masquerade to be experts, whereas we are not. Okay, so masquerade is pretentious. Okay, we all like to deceive each other the whole day. So does the inflammations. And why should we be suspecting, or how we should be suspecting? Because these are the patients, if you don't suspect, because they are going to present to you, if you don't suspect, they are going to be fatal. And you are having a big liability on your shoulders, and there's no defense. So they may be unusual, they are not very common, but I believe that these are getting commoner now in the last few years. Earlier we used to hardly ever see. So you need to have a very high index of suspicion. And as I said in the morning, right in the beginning when you see a patient, you need to be cautious, particularly about patients who are coming at extremes of age, unusual clinical presentations, and not responding to the usual treatment. These are like hot potatoes. Mind it, if a patient is not responding to your treatment for a reasonable time, maybe a week, maybe 2 weeks, don't keep them. You'll burn your fingers keeping that patient, the hot potato in your hands. So pass it on to the next guy whom you want to, you're not very friendly. So I have shown you in the morning some of these patients. So first thing you have to see whether a hypopion is accompanied by a fibrinous response or it's not accompanied by a fibrinous response. So depending upon, like young adult, here you would think of acute anterior uveitis, here you will think in terms of a Behçet's disease. So there's been so much talk about these two entities in the morning. But if you are seeing hypopion in a child, think of a masquerade, and most of the time these are, now patient may say, well, it's very important that to realize that they will not come up with the medical history, and you have to be really ferreted out of them, because they will most of the people have very poor opinion of eye surgeons. They either think us that they'll remove the cataract, or they give the glasses, or what does the guy know about leukemias and lymphomas and malignancies. So they will not voluntarily give you this history. But tum apna aankh ka dekho kya tum puchte ho hamare se. So you have to be really, really chasing them, because remember, eye is a niche for some of these cells which are hiding from the immune system or from the chemotherapy. They sequestrate in the eye. This is a very favorite site for sequestration of lymphocytic cells. Or like in this particular patient, we got cheated. Old man, he was a 72 years old man, and he had some kind of fever for about a week. And he says, I have got backache and just light perception and contact vision. And when we do the ultrasound, the vitreous cavity is full of high echoes, and we thought that, well, this guy has probably some kind of endogenous endophthalmitis, and we ordered for blood culture as well as the urine culture, and well, the cultures are positive. He has Staph aureus and both in the blood and culture positive from the urine for the same organism, and we do find that, well, he has L5 fracture, and a bone scan is done to figure out why does he have fracture. And keeping in mind, now we have an organism both from blood and urine, so we treat him on ceftriaxone, thinking that this is an endogenous endophthalmitis. But he continued to deteriorate. At that point of time, we thought, let's do a vitreous surgery and find out, because that's what you do for endophthalmitis. You're not responding to your conventional treatment. So the right eye underwent the partial vitreous surgery, and lo and behold, the cytology shows a diffuse large B-cell lymphoma. Now, unfortunately, during all this exercise of getting the bone scans and the blood cultures, and the vitreous surgery, and by the time the cytology report, we had lost precious 10-12 days, and the patient died on us in our ward. Now, this is the whole tragedy, that if we don't suspect it quickly, if you delay it, you are going to have some of these things, having a huge burden on you forever in your life. I think this particular patient is again a very, very significant issue. I learned my lesson for my lifetime dealing with this lady, just 40 years. As you can see, the left eye media is pretty clear. The right eye, there is the vitritis. She has reasonably good vision, just a few kps. And as you would have seen, we are obsessed with the TB in PGI. And lo and behold, she has 20 millimeter Montus positive, and X-ray chest also shows some healed specs. ESR is raised. So it's reasonable to think that this patient has tuberculosis, and she's duly started on 4-drug anti-TB drugs and prednisolone and the local treatment, but there is no response. So we give her posterior subtenon canalog, no response at 4 weeks, and then we give it again after 8 weeks. We are loading her with corticosteroids month after month. We add azathioprine, thinking that this patient is not responding to steroids. Nothing positive, just some degenerate cells and some reactive inflammatory cells. There is no clue until now. You can see the media is cleared after vitreous surgery. We find that she has these kind of very classic deposits under the retina. At this point of time, we like to do an OCT, and through one of these deposits, the OCT shows a very classic sub-RPE deposits. Clinically, now we are sure that we are dealing with the patient of primary vitreoretinal lymphoma, but trying to convince a patient that we are going to do a retinal biopsy. Vitreous biopsy is a different ball game, but now you want to say that, well, I'm going to do a retinal biopsy. It took time, and as you can see, another 5 or 6 weeks went by, and you can see how these lesion deposits keep changing. They're increasing, somewhere they're decreasing. You give them steroid, they melt away, they'll come back again. It's stuff like that. These cells are, primary vitreoretinal cells are sensitive to corticosteroids. Okay, so partly they'll respond. So anyway, we went in and we did the vitreous surgery, and at that point of time we thought we'll do a retinal biopsy as well. So we diathermize the whole thing, and from the nasal retina we pick up the retina, and then we find there's a very nice layer of these cells deposited under the neurosensory retina, which we use a soft tip to scrape off, can be easily scraped off and aspirated and subject to histopathology and cytopathology. The histopathology report from the retina comes normal, nothing wrong with the retina. But the cytopathology report says, well, this is very characteristic of B-cell lymphoma. Now we get worried. This patient has a B-cell lymphoma or primary vitreoretinal lymphoma. So we start worrying about CNS lymphoma at this point of time, and we seek neurology consultation. We do a bone marrow biopsy, and we do all stuff, There's no evidence on MRI, there's no CNS lymphoma. We treat her on intravitreal methotrexate, and she responds very well. And this is the regimen given anywhere you can find out, how we treat on methotrexate. These cells, lymphoma cells, are very, very sensitive to methotrexate. In fact, for CNS lymphoma, the ideal treatment is to give intrathecal methotrexate. I'll not go into detail. During all this episode, she had started developing the other eye also. You can see these small tiny lesions, which again responded very well to. Now this is around that time. So 30 months after the initial presentation, now 2.5 years later, she presents now. We are told in the morning that this lady who claims to have been under your care has landed in neurology emergency with seizures. And she had gait disturbance, facial nerve palsy, hemiparesis, cerebral signs, and spastic dysarthria. And they did all those MRIs, and they say, well, this is so classic of CNS lymphoma. And this is one of the standard treatment is external beam radiation therapy. So she received whole brain radiation therapy. I thought she is going to go vegetable after this therapy. She didn't. So she responded very well to external beam radiation therapy. So I'm showing you now 3 years after she first presented to us. She looks fantastic, 6/9 vision in both the eyes. She's doing very well. 4 years, you're following her up on regular MRI scans and just showing you the documentation. She's very good at 4 years. 5 years after the initial presentation, she was doing very well for CNS as well as the ocular lymphoma. There is no recurrence. 7 years after the initial presentation, I was told that she died in the neurology department. So she lived 7 years and she will haunt me forever because we delayed. So when the patient is not responding, we thought of TB, not responding, we thought of autoimmune intermediate uveitis. We gave steroids, oral, subtenon, and whatnot, 1, 2, 3. So you have to be pretty foolish not to think even once, why is the patient not responding? And you spend 1.5 years. But unfortunately or fortunately, that is the average duration after initial presentation of the patient when we are able to make a diagnosis of lymphoma. So what we learn from this person is that they may present as dense vitritis and vasculitis. You need to have a very high index of suspicion. This patient was a great teacher to us. And one of the major clues we got in this patient was subretinal, those classic OCTs, signatures of PVR lymphoma, and you should not rest content with one biopsy doing from the vitreous only, because sometimes these cells, if the patient is already receiving corticosteroids, the biopsy may come as degenerate cells or reactive lymphocytes. So you need to stop before you do a biopsy. You need to stop steroids for at least a couple of weeks before you will get in positive results. Now, if I go back and see what their early signatures of PVRL, so here is at 3 months this is the angiogram. Now what see here is a little bit of leopard skin kind of appearance. There are hypo and there are hyper, some of these lesions. And when you look at this, now if I saw this kind of perivascular leak now with hypo and hyper, I would always think of PVRL. And of course at 15 months you can see this is very classic kind of leopard skin. Now if you saw this, you would think of. Another patient I'd like to share, again a great teacher. This is a lady who is presenting with bilateral loss of vision. She is symptomatic for 1 year, and she is already, before coming to us, she is already receiving anti-TB drugs for a year, and vision is very poor. Now what does she have systemically? She has hepatomegaly. Right kidney shows a high flow AV malformation. She has calcified pleural plaques in the left side of the lung, and she has undergone a lymph node biopsy. And that biopsy shows that she has reactive lymphoid hyperplasia. Okay, on the final aspiration biopsy. What do we do? So we thought we'll subject her to vitreous surgery. So we did the surgery. After 2 weeks after presentation, she underwent, and you can see the fantastic view of the retina. Cytology was not very revealing. Activated lymphocytes, PCR was negative for all the stuff that we did. Now, something smart we did was we saved this vitreous fluid, hoping that one day our lab will be able to do cytokines. Okay, and we stored it minus 80 degrees Celsius. And then we forgot about it for about a year. And she developed a little bit of cataract, here as you can see. For the next 6 months we followed this lady. The vitreous fluid is lying stored. 1 year later we received the kits that are required, needed for doing cytokines. And this shows what? IL-10, 201. Now this is a cytokine which is supposed to be anti-inflammatory. In inflammatory disease, if IL-10 level goes up more than IL-6, which is a pro-inflammatory cytokine, that means you are not dealing with inflammatory disease at all. So when we see this alarming rise of IL-10, now our antennas are up. Oh my God, let's look around. This lady has lost to follow. And we look trace her records. I asked Rima to look for where is this lady, and we could find a telephone number, and we called, and she was admitted in a hospital. Guess where? In Ludhiana, on deathbed. She was dying of CNS lymphoma, and she died. Her son was very nice, very kind. He provided us with the MRI scans. So the lesson we learned was that cytokines, IL-10, IL-6 ratio from the aqueous humor, or better still from the vitreous humor, is a great tool to diagnose primary vitreous lymphoma. We were sleeping on this patient for 1 year. I will never do that now. That's a lesson. This gentleman, he's again 66 years, symptomatic for 6 months, and he's also received somewhere, posterior subtenon canalog for God knows for the uveitis. Now, the moment I look at it, I said, this guy doesn't look like posterior uveitis. Let's do a biopsy. And then we did a 25 gauge diagnostic with a provisional diagnosis of, and this time we are not doing now really we are not cutting out a disc of retina, neurosensory retina, because we just make a small tiny hole and use a soft tip, and all these cells are lying loose, and they can be easily aspirated into your through your soft tip cannula, and that's what we did. As you can see, this can easily be aspirated, and we do it under air and replace it later with, and we did a little bit of laser there, and lo and behold, right on the table when I was doing this aspiration, I thought this is primary vitreoretinal lymphoma, nothing else, and we injected 200 microgram under air of methotrexate, and cytology of course confirmed our suspicion. Now you can see this. She was followed with the routine, the usual methotrexate, and what I want to show you is the efficacy of methotrexate. Within 2 weeks, you can see the difference here. Once you make a definitive diagnosis, you know how to treat. That's not the challenge. Treatment is never a challenge if you know what you are treating. And here it is, what it looks. Within 2 weeks, all those lesions have gone away. We followed her. This is at followed him about 4 weeks, and this is, I think, about 6 months or so. The fellow is pretty good. I'm sure after I left the PGI, the guy has been followed still further. Now, the learning point from this particular case that these deposits can be aspirated through a soft tip cannula. You really don't have to do, because it can be scary trying to cut a disc of retina, and you don't have really expert pathologists who deal with the retinal tissue, which may be at best 1 or 1.5 or 2 millimeter in size, and during sending it to the lab, the tissue gets lost. The primary vitreoretinal lymphoma is sensitive to methotrexate. Of course, it is sensitive to now rituximab. It was not available then, now it's available, and you can definitely reduce the number of injection of methotrexate when you combine it with 1 milligram with rituximab in 0.1 ml. We also know that 20% of the primary CNS lymphoma will develop retinal lymphoma, but it's the other way around. Most of the patients who have primary vitreoretinal lymphoma will go on to develop CNS lymphoma. So you must remember that. So it's your responsibility to get them tested for CNS lymphoma, and perhaps not the other way around, and keep them followed. Now this, I think, very briefly, she has been exposed to this patient by Dr. Vishali, and you can see this is a 65 years old lady, and she already has this looking, we don't know what it is, it looks like some kind of a retinitis pigmentosa. And this lady, again, we had a challenge, and we thought we will, and this just to show that within 3 days, these deposits are moving around. We were trying to do some funny things, making them lying on the right side and left side. We were trying to see, if these cells would move around in the subretinal space, and actually they were moving, they were mobile, and this is what it shows here, if you get it. Okay, and she's shown this angiogram, so very classic of the vitreoretinal lymphoma. Of course, the cytology gave the diagnosis, and now this time we did get an MRI, and which did show that there was the primary CNS lymphoma associated at this point of time in this lady, and she also received external beam radiation as well as the intrathecal methotrexate she received from the Department of Neurology. And you look at it, both eyes look the same now. So the question here is was this representing a spontaneously regressed B-cell lymphoma? Because after radiation and treatment, it looks exactly the same. So this I have said already, and I'd like to sum up and say that many of these patients are confused with infectious uveitis. There is always a delay on an average world over, because there are not too many of these cases going around. But I believe in the last USI meeting, they already got the first prize in a poster presentation from the department, which represents, I think, these 12-13 cases in the last 4 years or 3 years. And that means we saw in the previous 20 years 12-13 cases, which we, I think, published a couple of years ago. And another 12 or 13 cases have come in the last 2-3 years. So probably our index of suspicion is improving, or maybe these cases are now getting more frequent. And must remember that any patient, as I said, who is not responding to your conventional care, don't hold on to those patients. Don't hold on to those patients. Pass them on to the next higher person or center. Thank you very much for the opportunity. Thank you.